Good afternoon, everyone. Thank you so much for joining today's webinar. My name is Kate Morars, and I'm the Senior Program Director of the Hepatitis B Foundation and Director of Hep B United Coalition. We're excited to present today's webinar in collaboration with the National Viral Hepatitis Roundtable on eliminating the public health problem of hepatitis B and C in the United States. Before we get started, I'd like to review a few housekeeping items and let you know how you can participate. Please note that all attendees are in listen-only mode and muted during the presentations. There's also a phone-in option, and the call-in numbers are shown on the screen. And if you have any questions, please feel free to submit them in the question box in your control panel at any time during the presentation. We will review them as they come in, and we'll hold a Q&A period after the presentation. And finally, today's webinar is being recorded. You will receive an email with a link to view a recording of today's presentation. And we'll go ahead and introduce our two host organizations, and I'll start off with Hep B United. Hep B United is a national coalition that was established by the Hepatitis B Foundation and the Association of Asian Pacific Community Health Organizations to address hepatitis B. The coalition is organized across 22 cities and 17 states. Hep B United Coalition partners are working to raise the profile of hepatitis B and liver cancer as an urgent public health priority, working to increase hepatitis B testing and vaccination and improve access to care for individuals living with hepatitis B to prevent liver disease and liver cancer. If you're interested in joining our coalition, please feel free to email connect@hepbunited.org with any questions. And I'll turn it over to Brian Clary, the Executive Director of NVHR, to talk about the coalition.
Great, thanks, Kate. And I want to thank Hep B United for partnering with NVHR on this webinar, and welcome everyone. And thank you for taking the time to be on the webinar today to learn more about this report. So for those who aren't familiar with NVHR, we're a broad coalition of almost 500 organizations around the United States working to fight and ultimately end the hepatitis B and hepatitis C epidemics. We seek an aggressive response from policymakers, public health officials, medical and healthcare providers, the media, and the general public through our advocacy, education, and technical assistance. And I invite you to check out our website, nvhr.org, and if your organization is not yet a member, please consider joining us. And we are also a proud sponsor of the strategy, the Elimination report that we'll be hearing more about today from the National Academies. So it's my pleasure to introduce our featured speaker today, Dr. Brian Strom. Brian Strom is the inaugural Chancellor of Rutgers Biomedical and Health Sciences and the Executive Vice President for Health Affairs at Rutgers University. He chaired the National Academies Committee on a National Strategy for the Elimination of Hepatitis B and C. I also want to introduce Jillian Buckley, who's on the line to answer questions and help with comments and feedback after the presentation. And Jillian was the study director for this important report. I want to thank both of our panelists today for their tremendous work putting out a real game-changing report that's really moving hepatitis B and C advocacy to a whole new level for us. So Dr. Strom, I'd like to turn it to you for your presentation.
Sure, thank you. If I can have the first slide, please. What I'm going to be talking about today is our report released, I guess, about a week ago or so on a national strategy for the elimination of hepatitis B and C. And we're very grateful to the committee, myself representing the committee. I'm very grateful to our sponsors for giving us the opportunity to do this. Next slide, please. My presentation, I'll talk about a statement of task, summarize the public health significance of these two diseases, talk about targets that we came up with as part of our process, and then information, intervention, service delivery, financing, and research. And I'll describe why the order, what each of those mean, and why the order for those in a few minutes. Next slide, please. First, the statement of task. This was a two-part report. Phase one, which was released a number of months ago, was, is it feasible to eliminate hepatitis B and hepatitis C from the United States? Our answer was yes, but not likely without attention to barriers. Phase 2 is the report that we've just released that I'm talking about today. And the question there is, what exactly is the strategy to eliminate viral hepatitis from the United States? Next slide. First, the public health significance, and I'm sure the people on this call recognize it, but to be explicit, chronic hepatitis B and hepatitis C infections affect 3 to 5 times more Americans than HIV. Worldwide, it's 10 times more common. Viral hepatitis kills more people worldwide than HIV, road traffic injuries, or diabetes. Despite being the 7th leading cause of death in the world, viral hepatitis consumes less than 1% of the NIH research budget. 1.3 million Americans have hepatitis B, 2.7 million of hepatitis C. Hep B and Hep C account for about 80% of the world's liver cancer. Chronic hepatitis B increases the odds of liver cancer 50 to 100 times. Hepatitis C increases it 15 to 20 times. So with those increased risk and the high incidence of the high prevalence of these conditions, viral hepatitis is driving the 38% increase in liver cancer in the US that was observed between 2003 and 2012. So when most kinds of cancers in the US are decreasing, liver cancer is increasing, and it's these two diseases that are thought to be the reason. Next slide, please. Very important in the recent past, the environment surrounding these two diseases has changed. First, there's an effective vaccine now, hepatitis B, as a prevention. And in addition, most recently, new treatments can cure the vast majority of hepatitis C patients. Treatment for hepatitis C is expensive, and we'll talk more about the financial implications later in the talk, but it's still cost-effective compared to other interventions, meaning it's not free. There is a cost associated with it, but it is so effective that if you compare its benefit to its cost, it actually compares well compared to most things we do in medicine in the United States. It is possible, we feel, to eliminate hepatitis B and C in the United States as a public health problem, averting about 90,000 deaths by 2030. This report is a roadmap on how to get there. Next slide, please. In 2016, the World Health Assembly passed a resolution to eliminate viral hepatitis by 2030. Member states are developing national strategies for elimination, and I'm happy to say that the U.S. apparently is the first state to complete this strategy, which is what we're talking about today. And the World Health Assembly recommended that each national strategy should consider 5 strategic directions. The first is information for focused action, the who and the where. What information is needed in order to be able to achieve hepatitis elimination? The second strategic direction 2 is what are the interventions needed in order to have the needed impact to eliminate hepatitis as a public health problem, the what. Third is strategic direction 3, delivering for equity, the how. Now that we have the interventions, how do we get them to the people who need them? A different problem than having the interventions is making sure they're used correctly and used in the right people. The fourth strategic direction 4 is financing for sustainability. How do we afford this? As I alluded to, these are expensive treatments, particularly for hepatitis C. How do we figure out a way to be able that the country can afford to do what's needed between now and 2030? And we'll make some suggestions there. And finally, strategic direction 5, research. What research is needed in order to be able to put the prevention and treatment of hepatitis in a better place in future years. Next slide, please. So first thing we did is choose hepatitis B and hepatitis C targets. This was done largely based on modeling. Basically, what is a reasonable reduction that could be achieved between now and 2030? Focusing on hepatitis B targets, we felt that a 50% reduction in mortality from chronic hepatitis B is possible in the US by 2030. This would avert over 60,000 deaths. Meeting this goal, though, would require diagnosing 90% of chronic hepatitis B cases, bringing 90% of those who are diagnosed to care, and treating 80% of those treatment is indicated. The same level of diagnosis, care, and treatment would reduce new cases of hepatitis B associated liver cancer by about a third, and new cases of hepatitis B related cirrhosis by about 45%. The elimination of hepatitis B virus infection in neonates and children under 5 is also possible. This did not come out of our modeling, but it's been demonstrated in Alaska natives, where in fact that transmission has been eliminated. So we think partly modeling, mostly based on modeling, and partly based on the Alaska native population, that a very substantial change in prevalence of hepatitis B could be, incidence and prevalence could be implemented between now and 2003, with very substantial reductions in mortality cancer cases along with that. Next slide, please. Moving on to the hepatitis C targets, a 90% reduction in the incidence of hepatitis C is possible in the United States by 2030. It's important to realize that that's a 90% reduction relative to 2015, where we already in the last few years have had significant progress given the new treatments. But meeting this goal would require treatment without restrictions on disease and a consistent ability to diagnose new cases, even as prevalence decreases. Let me comment about both of those. Right now, most treatments are reserved for people with the most severe disease, but the people with the most severe disease are not the ones most likely to passing the disease onto other people. The people with the most severe disease, cirrhosis, emerging from it, are people who are likely to be older and have had the disease for a while. So in order to be able to meet this elimination goal, we really need to require treatment without restrictions about severity. The other thing is we need to achieve treatment, a consistent ability to diagnose new cases, even as the prevalence decreases. Most of this disease is subclinical and requires careful detection of cases, and as more and more cases are treated and cured, detection of the cases will become harder. The same levels of diagnosis and treatment would reduce mortality from hepatitis C in 2030 by 65% relative to 2015, and would avert 29,000 deaths by 2030. Meeting these targets would depend on diagnosing at least 110,000 cases a year until 2020, almost 89,000 a year between 2020 and 2024, and over 70,000 each year between 2025 and 2030. Next slide, please. So moving on to our recommendations, the first was that hepatitis elimination will require coordinated action from various federal and state government agencies. We have a number of recommendations that you'll hear about to different federal and state agencies to make sure that these all work together smoothly and optimally. A leadership of a single office would help ensure efficient and harmonious work. So our recommendation is that the highest level of federal government should oversee a coordinated effort to manage viral hepatitis elimination. Next slide, please. Moving on to information. Not all state and local health departments are in a position to measure hepatitis disease burden. Integrated, highly automated electronic surveillance systems could go far toward a more accurate understanding of viral hepatitis disease burden. So our recommendation is that the CDC, in partnership with state and local health departments, should support standard hepatitis case finding measures and the follow-up, monitoring, and linkage to care of all viral hepatitis cases reported through public health surveillance. CDC should work also with the National Cancer Institute to attach viral etiology to reports of liver cancer in its periodic national reports on cancer. Right now, NCI runs the SEER network, a network across the country of cancer, population-based, geographically defined cancer registries, where all cases of cancer are reported in that geographic area. Right now, it identifies that NCI then aggregates the data from the SEER registries and projects it nationally to calculate the burden of cancer in the country. But it doesn't attach to reports of liver cancer whether or not the liver cancer cases were virally related or not. As the course of the epidemic, course of the treatment proceeds between now and 2030, we would anticipate that more and more of the cases would be non-virally induced, or rather fewer and fewer cases would be virally induced, and it would be very useful for CDC and NCI to specifically track that in order to be able to guide the treatments and evaluate the success of the program as time goes on. Next slide, please. Continuing on with information, a better understanding of the epidemiology of viral hepatitis comes from research in high-risk populations. Such research can help clarify the true incidence and prevalence of hepatitis B and hepatitis C infection. Our recommendation is that CDC should support cross-sectional and cohort studies to measure hepatitis B and hepatitis C infection incidence and prevalence in high-risk populations. Next slide, please. Moving to essential interventions, hepatitis B is vaccine preventable, but only about a quarter of adults older than age 19 are fully immunized. We do much better with flu vaccine than we do with hepatitis vaccine. So our recommendation is that that states should expand access to adult hepatitis B vaccine, removing barriers to free immunization in pharmacies and other easily accessible settings. So for example, right now you can walk in many states, you can walk into a pharmacy and get a flu vaccine. You can't necessarily walk into a pharmacy and get a hepatitis vaccine. And that should be changed by the states where that's needed. Next slide, please. Early testing for hepatitis B viremia can help determine the best course of treatment for hepatitis B surface antigen positive pregnant women, balancing questions of drug resistance and hepatitis flare against the risk of mother-to-child transmission. Our recommendation is that CDC, ASLD, IDSA, and ACOG should recommend that all hepatitis B surface antigen positive pregnant women have early prenatal hepatitis B virus DNA and liver enzyme tests to evaluate whether antiviral therapy is indicated for prophylaxis to eliminate mother-to-child transmission or for treatment of chronic active hepatitis. Next slide, please. The most effective way to prevent hepatitis C among people who inject drugs is to combine strategies that improve the safety of injection with those that treat the underlying addiction. People who inject drugs account for about 75% of new hepatitis C infections. This is obviously even more important nowadays as the country suffers from an opioid abuse epidemic. So our recommendation is that states and federal agencies should expand access to syringe exchange and opioid agonist therapy in accessible venues. Next slide, please. There are settings where increased screening could pay off handsomely, but screening can put a burden on the health system and providers. Society stands to benefit from any measure that sheds light on the subclinical burden of hepatitis B virus and hepatitis C infection. So our recommendation is that CDC should work with states to identify settings appropriate for enhanced viral hepatitis testing based on expected disease prevalence. Next slide, please. Curing hepatitis C has clinical benefit, including reduction in cirrhosis and normal return to normal liver function. Treating everyone with hepatitis C, regardless of disease stage, as I was talking about before, would avert considerable suffering in patients. It would also protect society by reducing the population reservoir that might spread infection. Our recommendation is that public and private health plans should remove restrictions that are not medically indicated and offer direct-acting antivirals to all chronic hepatitis C patients. Next slide, please. Service delivery. This is moving now from interventions to how do you get the interventions to the people who need it. There are gaps between the practice of medicine as recommended by experts and what really happens. NCQA is interested in closing these gaps. The HEDIS indicators that NCQA works with command a certain attention from providers and health plan managers. Our feeling was that inclusion of viral hepatitis in HEDIS would increase attention to these services. So our recommendation was that the NCQA should establish measures to monitor compliance with viral hepatitis screening guidelines and with hepatitis B vaccine birth dose coverage and include these new measures in HEDIS. Next slide, please. One of the main bottlenecks in hepatitis care is the need for patients to be treated by specialists. As a result, viral hepatitis care remains out of the reach of people in rural and underserved areas. Yet with the new direct-acting antivirals, you don't necessarily need specialist treatment in this way. So our recommendation was that ASLD and IDSA should partner with primary care providers and their professional organizations to build capacity to treat hepatitis B and C in primary care. The program should set up referral systems for medically complex patients, of course, to be referred back to the specialists. Next slide, please. The people most affected by viral hepatitis can be hard to reach. People with the most serious need for health care, including people with behavioral health problems, need more support services. So our recommendation is that the Department of Health and Human Services should work with states to build a comprehensive system of care and support for special populations with hepatitis B and C on the scale of the Ryan-White system. So again, whether or not the Ryan-White system itself is used, because obviously it's a similar population, HIV population is similar population to the hepatitis population, or whether something else was created, we thought was beyond our scope to recommend the distinction. Next slide, please. Incarcerated people bear a disproportionate burden of viral hepatitis. This is an opportunity. Jails and prisons are an ideal place to vaccinate against hepatitis B and treat hepatitis C. So our recommendation is that the criminal justice system should screen, vaccinate, and treat hepatitis B and C in correctional facilities according to national clinical practice guidelines. Again, this raises financial questions that we'll address momentarily. Next slide, please. Eliminating hepatitis C in the US depends on treating, in our modeling, at least 260,000 patients a year with direct-acting antivirals. That's the number we're treating now. Yet none of these drugs will come off patent before 2029, 1 year before the target elimination date. These are very expensive drugs. One could delay mass treatment, but that would result in tens of thousands of deaths and billions of dollars in wasted medical care costs. So our recommendation is that the federal government, on behalf of HHS, should purchase the rights to a direct-acting antiviral for use in neglected market segments such as Medicaid, the Indian Health Service, and prisons. This could be done through the licensing or signing of a patent in a voluntary transaction with an innovator pharmaceutical company. Let me spend a few minutes talking about that. This is an unusual suggestion, but completely voluntary, would require no legal change at all. We are in a unique situation here where we have multiple different drugs, all of whom are terrific products. On one hand, all are effective, all are expensive. You don't want to get in the way of innovation for future great products like this by having the companies not be able to benefit financially from their investment and the risk they took. On the other hand, there is relatively little use right now in Medicaid populations and prison populations, not zero, but relatively little. The companies are mostly making their money in private patients and people with insured populations. So the suggestion here is that the license be purchased by the federal government for use solely in those relatively neglected populations, the Medicaid populations and prison populations. And with that, it would end up being a voluntary process where the companies would bid, competing against each other to provide it, and would ultimately be a win-win-win. The federal government would get it cheaper. The company would actually make more money. The winner of the bid would make more money because it would be selling into a population it's now selling very little in, and obviously a massive public health improvement because you'd be able to treat all of these people in these key high-risk subgroups. Next slide, please. Finally, research. There can be no elimination of viral hepatitis without better attention to research gaps. Our report lists two different kinds of suggestions about research. One is mechanistic research questions, including development of curative therapy for chronic hepatitis B infection, and development of a hepatitis C vaccine. We also suggest a number of implementation research questions, including stigma alleviation, understanding networks of drug users, and health and incarcerated people. Next slide. Finally, I'd like to thank these members of my committee and staff, these who are listed here, and Jillian Buckley, who's on the call as well, was study director, leading the staff. These are the people who really did the bulk of the work. That I'm simply here as their representative. So thank you very much.
Great. Thank you, Dr. Strom. We'll now begin the question and answer portion of our webinar. As mentioned at the beginning, if you have any questions, please type them into the question box, and we will read them out to Dr. Strom and Dr. Buckley. We do have a question from Karen Kim at the University of Chicago. How does the hepatitis B strategy take into account the rapidly growing immigrant and refugee populations? Were these growing populations included in the modeling framework?
The hepatitis B modeling, and Julian may want to chime in here too, the hepatitis B modeling certainly took into account the fact that there would be continual inflow of new cases. So the goal here, keep in mind, was to eliminate hepatitis B or hepatitis C, as the case may be, as a public health problem, not to eradicate it. We did not think it was possible to completely eradicate it because in the case of hepatitis B, there will be a continual influx of new cases. But if you prevent its spread from children to from mothers to children in hepatitis B, and if you treat cases that are already here, detecting and then treating cases that are already here, you could prevent the bad outcomes, the cancer, the cirrhosis, from hepatitis B as part of that.
And I think I would just add to that model in particular, the hepatitis B model, the modeler presented a results in terms of percentage improvement in number of people diagnosed, percentage decrease in terms of end-stage liver disease and other bad outcomes. So given that she's looking at the percentage, the influx, the absolute number of patients in the population is less important.
Thank you.
Sure.
Our next question from David Lentz is, which populations should be screened for hepatitis B and C to link them to care, STDs, methadone clinics, etc.?
Yeah. Again, we didn't get into that in great detail. I mean, these are you know, we certainly aren't changing recommendations, but the populations that should be screened are the conventional populations that are now recommended to be screened, the high-risk populations, IV drug users, prisoners, and populations of that sort.
Yeah, all I could think to add was that the report talks about, you know, as time goes by, it might be more difficult to find patients. And if you want to keep hitting your targets to actually have a stronger public health effect, you're going to have to pay more attention to screening, to finding new patients. So the report talks about CDC trying to find some novel venues for increased screening. It's definitely not within the committee's remit to change, you know, CDC or ACIP recommendations about screening. But so yes, the committee recommended the CDC work with their partners to find, especially over time, to find new settings to screen in where screening beyond risk-based screening might be helpful. And we talk a little bit about screening in the prison system, particularly in so much as we're recommending that the criminal justice system be treating more people. But I'm not sure that that's really the same as the level of detail that the questioner was asking for there.
All right. Our next question is, in the absence of a tremendous increase in federal funding, are there national strategies that we might prioritize in the interim?
Yeah, our recommendations do not call for a tremendous increase in federal funding. Rather, we call instead for this licensing approach as a creative approach to be able to markedly increase treatment and particularly focus treatment in the high-risk populations without a marked increase in funding.
Okay. Our next question is, how much do you anticipate the cost would be to treat everyone with hepatitis C?
With hepatitis B, I don't know that we went through that that calculation. Sorry.
It's hepatitis C. Sorry.
Hepatitis C. Julian may remember offhand if we did a calculation there. But again, with our financing recommendation, our suggestion is there would not be a marked increase in cost. Rather, so let me be more concrete. Right now, over the next 10 years, the companies will sell about $10 billion worth of hepatitis C treatments in these high-risk populations, that Medicaid prisoner populations. But that's a relatively small market. Like only 1% of prisoners are in fact being treated. With the same amount of money or less, we should be able to buy the license. And with that license and manufacturing it at the cost of a generic manufacturer, which we estimated at about $140 million a year instead of the $10 billion over the course of 10 years, or $2 billion a year, we should be able to essentially treat almost the entire high-risk population. So with this approach of using the purchase of the license and purchasing the license specifically only for the high-risk populations that are mostly not being treated now, there would be a relatively small increase in cost, and with that be able to treat almost the entire high-risk population.
So our report offered a figure of $2 billion plus, like let's call it $2.2 billion. That would just be for the Medicaid and prison markets. Now, I think the questioner was asking about treating everyone with hepatitis C. That's not something that we get into, because most people who have hepatitis C, like most people in the United States, have some sort of form of private insurance or Medicare. Those patients are not generally, it's not as common for them to be denied treatment, so we didn't really get into that. Basically, everybody is quite a lot of people, and we were really only interested in the people who are otherwise not able to access.
Yeah, and the 2.2 billion that Jillian was alluding to, which I rounded off to the 2 billion, are really the people who are now getting treatment, and so which is in the high-risk populations. So these are expenses that are now being incurred. They're just being incurred because of the expense of the drugs. They're treating a very small proportion of this high-risk population. Using this licensing mechanism, essentially the same cost, the same expenditure would treat a dramatically higher proportion of that population. But as Jillian alluded to, this says nothing about the costs to the rest of the population, expenditures which are now going on and being covered by private insurance.
Thank you. And then follow up, the next question is there an example of when this type of licensing occurred? If so, what drug?
There is not an example of doing it this way. This is an unusual situation because there are multiple different extremely effective treatments all available at the same time. Typically, when you have a novel treatment like this, either it's later in the lifetime of a drug and it's come off patent already, or it's earlier on and there's only one such drug. So it's unusual. There are examples. The federal government does have the legal right to essentially take on licensure. There have been a number of situations, Defense Department and otherwise, Night Goggles, for example, where that's happened in an involuntary transaction. That's not what we're suggesting. We're suggesting a completely voluntary transaction where basically the money that is being used now in order to buy access to the drug would be used instead for the high-risk population would instead be used to buy the license, and then could be provided to a much larger proportion of the high-risk population for a lot cheaper.
Thank you. Our next question is, given that the baby boomer population is gradually aging into Medicare, can you talk about the role of Medicare in eliminating hepatitis C? What aspects of the care continuum would most need to be strengthened?
Well, Medicare would clearly play an important role in elimination for those who have Part D, access to Part D insurance at least, because it'll pay for treatment for them. That doesn't play as large a role, though, in eradication per se, because the places where where the disease is being spread right now are disproportionately in the at-risk population. So, with only 1% of people in prisons, for example, being treated for hepatitis C, treating Medicare patients isn't going to make a large dent on that. So that gets back to my comment that when you're thinking about hepatitis C treatment, there's really two different populations. One are older patients who've been infected for a while and are at risk of the complications, and the other are younger patients who are really the reservoir from which the disease is passed person to person, and obviously Medicare doesn't help there.
Okay. Our next question, again related to funding, from Dr. Ron is, how do you propose that we improve surveillance for viral hepatitis without additional federal and state resources?
Yeah, as a matter of, let me answer in a couple of related ways. Firstly, as a matter of National Academy policies, we don't make specific recommendations about specific funding. So we did not say spend X number of extra dollars on screening programs. Whether or not ultimately there is a need for new dollars, or whether it's a need for reprogramming existing dollars from other programs, is really up to the CDC and its partners to decide. But clearly there has to be additional investment in detecting cases, referring cases, monitoring cases. In those states that don't have that capability now, there's very few states that have that capability now. There are demonstration projects funded by CDC that needs to be expanded. But again, exactly where those funds should come from was not within the scope of our charge.
Okay. All right, our next question is, again, relating to the financing structure, what incentive would the pharmaceutical companies have to sell a license to manufacture their drugs? Wouldn't their profits be reduced?
Well, sir, what was the second half of? Wouldn't their profits be reduced? Is that your question? The second half. The profits actually would increase if they are awarded this contract, because the license doesn't in any way inhibit their continuing ability to make money on insured patients. It is simply getting them more completely into a market that they're now barely in. The incentive they'd have is a profit incentive. They'd make more money if they license it. Those companies that do not license it will make zero money. So they'll be pushed out of this market. What this licensing would do is it would take the money that is now being spent on Medicaid patients and prison patients and use it to buy the license. So of the roughly 5 companies that have products, the one who wins this license makes more money. The ones who don't win this competition make less money. So there, again, a strictly voluntary transaction with the idea that the people who taking advantage of this unique situation and the competition that exists among the different companies.
Okay. Our next question is from Henry Chang. Did the committee consider pay for performance financing model, whereby the government pays a fund manager if X number of people are diagnosed or cured, as determined by an independent auditor?
I guess I'm not fully sure where So we didn't specifically talk about pay-for-performance models. I'm not sure in the context in which the questioner is referring to it. So if a pay-for-performance model within a public health system, sort of CDC paying state health department or county health department to detect cases per case, would be, it's not a model I'm familiar with having been used. I don't know that we discussed. Within a health system per se, how to motivate a given health system in order to be able to detect more cases. It was our suggestion for vis-a-vis NCQA and HEDIS measures, rather than specifically paying physicians to diagnose cases.
Great, thank you. Our next question is, screening and diagnosis of hepatitis C positive individuals remains a challenge without additional federal and state funding. Does the report explore innovative ways to achieve the report's screening goals?
We certainly talk a lot about the need for increased screening. We do not talk about where the financing for that would come from.
Okay.
And again, just to be clear, just to be clear, as I said before, we were not asked to. We stick to our charge, and whether that comes from new funds or whether it comes from reprogramming of existing funds, obviously would be up to the individual organization. We don't make recommendations about increased funding unless that's specifically in the charge of a National Academy Committee.
Okay. Great, thank you. Our next question is, why, the individual is asking, why can't Medicaid and prisons negotiate a lower price with the pharmaceutical companies to lower the cost to the population not accessing the drugs?
So let me separate it in a couple of different ways. Firstly, they can, and certainly Medicaid has, for example, so people in prisons cannot access Medicaid while they're in prisons. So the different prison which is mostly state organizations, would need to band together and do that. Different Medicaid organizations would need, which again are state programs, would need to band together to do that. They can get discounts. They do get discounts, but the discounts aren't. And in fact, by law, Medicaid gets a best price compared to other organizations, but it still remains extremely expensive, and it's still mostly not used. The amount of savings involved isn't anywhere close to the amount of savings that would be involved through our licensing suggestion. So again, what we're suggesting is not that people get a discount and thereby get a little bit more treatment. So you go up from 1% treated to if you double it, it's only 2% treated. And if you triple it, it's 3% treated. Well, what we're talking about is taking those same funds and using those funds to buy the license and thereby be able to buy the drug at what would be generic rates, which would be a tiny fraction of the brand name rates.
Thank you. Our next question is, did the committee identify what some of the barriers are that keep pharmacists from being able to deliver the hepatitis B vaccine?
Yeah, it's really state law, different, and it varies obviously by state. But pharmacy is regulated by the states, and some states allow pharmacists to dispense hepatitis vaccine in the pharmacies, and some do not.
Thank you. All right, so if there are any other questions, please continue to submit them in the question box. And I wanted to just check in with Ryan as well if you have any comments or questions you wanted to add.
I have a question that has certainly come up since the report came out, which is sort of the top line recommendation of, urging the highest level of coordination within the federal government of an elimination strategy. Did the committee identify, I know you talked about a few in the report, sort of any specific recommendations of whether that be a position or an office where it might be housed? This is something that advocates have started to sort of rally around as one of our first advocacy strategies.
Yeah, we certainly talked about the need for this. There are lots of different options, as you saw in the report. You know, it could be in the White House, it could be in HHS. We especially with the new administration on board, but even regardless, we didn't think it was appropriate for us to make specific organizational suggestions. It really would be up to the federal government to decide, given how they're organizing or reorganizing, where the best place is. But it needs to be broader. It's not just NIH, for example. It's got to be broader. It's not just CDC. It's got to be broader. So whether it's out of HHS, whether it's out of the White House, whether it's out of some other structure that is set up, the key thing is the coordination. Whether it's a new office, whether it's an individual, the key thing is that it's important that all these initiatives be coordinated across the many different organizations that we're making recommendations to.
Great, thank you.
Thank you. I do have a question that just came in, Dr. Strom. My program has found that among the local injection drug using community, prevalence of Hep C is far higher among those who are homeless. Given that these would be a high priority group for receiving treatment in terms of reducing transmission, what resources does the plan recommend to address homeless populations, particularly in increasing community health outreach skills and activities to interact with this community?
Jillian, do you remember specifically, did we certainly talked about the homeless as a high-risk population. I don't recall if we had specific recommendations about the homeless.
Well, that came up in how it related to the recommendation about finding an infrastructure, either building off of Ryan White or something similar in size and reach to Ryan White. And in that part of the report, to reach people with viral hepatitis, and that part of the report talks a lot about special populations for viral hepatitis, people who are born abroad, people who have been or are incarcerated, people who are homeless or live on the streets even sometime. And we talked about those populations as being essential to the elimination effort, and then sort of said, states, in most states, the Ryan White coordinator has at least given some thought as to how to reach these populations that overlap a lot with HIV. Can states find a way to build off of that effort that they've already put to reach, to make viral hepatitis services more accessible? I'm not sure if the participant's asking for a specific recommendation about services for homeless people. Aside from, talking about federally qualified health centers, we don't really have specific recommendations of the sort that I think you might be looking for.
Thank you. And then just a comment from a participant that Maryland, just so folks know, Maryland pharmacists can immunize patients with Hep B vaccines. So as Dr. Strom noted, it depends on state law. Any other questions? And then Dr. Strom, will we be able to share the slides? We had many questions related to that with the participants after.
Yes, it's certainly fine with me, assuming it's fine with the Academy, Jillian.
It's fine. I would just ask you PDF those if you wouldn't mind.
Absolutely.
Okay. Thank you.
Great. Thank you. All right. Well, if there are no further questions, thank you everyone for all of the great questions that we received. If there were some that we weren't exactly able to answer or get to today, we will be sure to send you an email. I want to thank you, Ryan at NVHR and Dr. Strom and Jillian Buckley very much for your time today. And I'll go ahead and turn it to Ryan to close it out.
Great, thanks. Thank you very much, Kate, and thank you, Dr. Strom and Jillian, for your leadership with the report and for taking the time to share the strategies and to answer our questions. And I think I would say to everybody participating, we've been given this phenomenal tool with a lot of exciting recommendations that we can rally around. And I think Dr. Strom was clear that the panel had its charge of developing this strategy, and then now it's our job as advocates to move forward a lot of these recommendations. And while the report may not single out a lot of specific federal funding to move forward these recommendations, as advocates, we all know that we need a significant increase of funding at all levels of government. And so that's the work that Hep B United and MVHR and all of our advocacy partners will be doing. So if you're not connected with our organizations, please do join us, get on our listservs, and find a way that we can all work together to achieve the goal of eliminating the public health problem of hepatitis B and C in the United States and achieve a tremendous public health victory in the United States. So with that, thank you everyone again for being on the webinar today, and to our speakers, and to Hep B United for partnering with MVHR. And have a great rest of the day.
Thank you.
Thanks for having us, Ryan.
Take care.
Okay.
Sure.
Bye-bye.
Thank you. Bye-bye.